So good morning, everybody, and thank you so much for lovely and long introductions. That's on me because I write it to you, right? So thank you so much, Haymar, and thank you the organizers for inviting me today, especially P. Stephen Ka. He actually asked me to do this back when we were in Germany together in the AIDS conference, and I said to him that if he wants actually for specialists to be the one who do this. And he actually said to me that he wanted someone who provide the services. And I agree with that a lot. And it resonates very well with the messages trying to convey by the W path, which try to de-specialize the field to give more accessible care to trans and gender diverse individuals. So with that, good morning, everybody. I hope you have a good night's sleep yesterday because I'm about to bombard you with a lot of information today. So without further ado, this is my disclosure. And let's start with why this topic is so essential, right? For those of you who are not familiar with gender affirming care, this is a term under the umbrella terms of gender affirmations. According to the Standard of Care version 8, published by the World Professional Association for Transgender Health, or WPATH, gender affirmation refers to being recognized or affirmed in a person's gender identity, which covers wide ranges of dimensions, including psychological, medical, social, and legal dimension as well. Gender affirmation has been used in lieu of the term gender transition, or it can be used as an adjective of gender affirming care. So when we talk about gender affirming care, we only talk about one aspect of a single dimension of the whole gender affirming care. There are other medical dimensions such as puberty suppressions and gender affirming surgeries, which will not be talked about today. So for gender-affirming hormone therapy, this only involves the provisions of hormone therapy that facilitates the recognition of or help fulfills a person's gender identity. Moreover, it also helps reduce mental health issues along with improving the body satisfaction and self-esteem. In the past, gender-affirming hormone therapy was limited to some medical specialists, which also limited the number of the people who could benefit from it, which is why WPATH emphasizes the importance of gender-affirming hormone therapy's accessibility in their latest versions of the standard of care. The guideline recommends any healthcare personnel who have been trained in the clinical field related to transgender health or equivalent clinical training or receive the statutorily regulated regulations can provide the hormone therapy and monitoring services. Moreover, healthcare personnel who have lower qualifications can also provide similar care under the qualified healthcare personnel. This means that a general practitioner like myself, or a nurse, or in some scenarios, just like Thailand, some lay providers can also provide gender-affirming hormone therapy. So to paint a clearer picture, all of you here today actually have a potential to become a provider for gender-affirming hormone therapy. So that is why it is so important for you to know about gender-affirming hormone therapy. If we are to, so let's start, right, with gender-affirming hormone therapy. Today, we'll be talking about the dosage and the numbers, which might be somewhat the knowledge that you acquired already, but let's talk about it anyway, no? So to classify gender-affirming hormone therapy, we might have to conform to the binary system. We can roughly classify this therapy into two categories. First, feminizing hormone therapy, and secondly, masculinizing hormone therapy. Let's start with feminizing hormone therapy. There are two objectives to this management. First is to increase the femininity of feminine characteristics through the use of estrogen and progesterones, and secondly, to reduce masculine characteristics through the use of anti-androgens. For estrogen and progesterone, both can reduce or induce female secondary sexual characteristics. However, in some instances, progesterone were reported to improve or induce the breast and areola development, mood, and libido. However, some guidelines, including SEF guideline, which is the main Thai guideline, do not recommend the use of progesterone for gender-affirming hormone therapy due to their side effects. And for anti-androgens, such as spironolactone and cyperterone acetate, these agents help minimize the male secondary sexual characteristics, thereby reducing masculine traits. Estrogens. These hormones come in many forms, including oral tablets, transdermal patches, and injections. However, in Thailand, estrogen injection is not approved by the Thai FDA. Therefore, most of the estrogens will come in the form of oral and transdermal forms. However, there are also various types of oral estrogens, some of which are recommended for gender transition. For example, 17-beta estradiol hemihydrate or estradiol valylate are approved for gender transition, while conjugated estrogen and ethinylestradiol, which is found in oral contraceptives, are not recommended due to their abilities to promote thromboembolism. And this brings me to a few important clinical notes here. Firstly, contraceptives pills that contains ethinylestradiol is not recommended to do the gender-affirming hormone therapy because it can increase the risk of cerebral cardiovascular diseases. Secondly, transgender women or other feminine presenting individuals assigned male at birth or AMAPs who had undergone orchiectomy still needs to continue the use of estrogen to maintain their feminine appearance and also to prevent osteoporosis. And thirdly, the alternative sources of estrogen, for example, plant-based estrogen, is not recommended for gender transitions because we cannot really determine the depth or the side effects of these kind of estrogens. Moving along to anti-androgens. As discussed, there are a few options that you can choose from, for example, spironolactone and cyperterone acetate, both of which is recommended for gender-affirming hormone therapy. However, finasteride, which is the 5-alpha reductase inhibitor, is not recommended by SEF guideline or Endocrine Society guideline 2017. These agents help remove the secondary sexual characteristics, for example, facial hair, body hair, and erections, which can greatly assist in the reductions of gender dysphoria in some individuals. Another important note on the use of anti-androgen is that, firstly, this is a personal choice. Some people want to preserve some masculine characteristics, for example, their sexual function, which correlates very much their sexual preferences and sexual pleasure. So some of them might not or prefer to take anti-androgens, and that is fine. Secondly, anti-androgens, they are not recommended to use alone without the use of estrogen because it will only reduce the male sexual characteristics but do not create the feminine ones. However, in some instances, such as individuals who identify themselves as a eunuch, they might want to decrease their male sexual characteristics without gaining feminine characteristics. And with that, they can also use anti-androgens without the estrogens. And thirdly, anti-androgen is normally not required after a person has received a genitalia gender-affirming hormone therapy, or gender-affirming surgery or orchiectomy, because there's no source of testosterone in the body anymore, so anti-androgen would be entirely pointless. And this slide shows the desired effects of feminizing hormones. Please note that the maximum onset of these effects will take approximately 2 years to see. So these effects will take different onsets to manifest in some individuals. The first attribute that the clients or our patients will see or experience is the decrease in sexual desire and spontaneous erections. Then comes the body changes, for example, the redistributions of body fat, breast growth, and decrease in testicular volume. After that, they may experience male sexual dysfunctions or scalp hair loss. However, the only attribute that cannot be changed through the feminizing hormone therapy was the voice changes. And with this, we recommend that an individual to seek the treatment by the speech pathologist, as it is the most effective way to change your voice. However, this feminizing hormone therapy does not offer only the desirable effects. It can also increase or heighten some medical risks as well. They can also moderately increase macroprolactinoma, breast cancer, and more. But most importantly, they also increase the risk of thromboembolic diseases. However, these risks, they are not the absolute contraindications for someone to receive gender-affirming care. However, providers, you need to be able to detect and give rigorous screening in order to minimize these effects from the gender-affirming care. Moving on to the regimens, right? We have a lot of guidelines all over the world. However, in Thailand, we also develop our own guideline through IHRI and the Center of Excellence in Transgender Health by Chulalongkorn University, or the CEF guideline. I would like you to tip your attentions to the far yellow panel, the brownish panel, which is the CEF guideline. This is the guideline that we follow in Tangerine Clinic. The initial dose for oral estradiol is 2 to 6 milligrams per day, which equals to 1 to 3 pills per day. The dosage for transdermal estradiol is 25 to 200 microgram per day, which equals to 1 measuring ruler per day. So as you can see, the gender-affirming care is not very hard for you to prescribe at all. And next thing, the 17-beta estradiols also come in patches. One patches will contain around 50 micrograms and will extend the release after 24 hours. For transdermal patches, we also start slowly. You can start with 1/8 of a patch, then graduate to 1/4 of a patch, and then to 3/4 of a patch, and then one patch every 3.5 days or twice a week until your clients has reached the target level of hormone monitoring. However, the transdermal patches, they are not very popular in Thailand at all because our hot and humid weather. So it's very hard for someone to put the patch on their body for twice a week, which equals 3 days, right? However, with some clients who prefer the transdermal patch, please make sure that they put it on the exposed skin. For example, on your lower abdomen area, and abstain from putting it on your hips area or your breast area because it will have a lot of creases which minimize the effects of the transdermal patch. This slide is also very important because it's tell us how we can monitor hormone monitoring services. According to the Endocrine Society guideline, estradiol level should be between 100 to 200 picogram per milliliters, and testosterone level should be lower than 0.5 nanogram per milliliters. However, some estrogen, including conjugated estrogen or synthetic estrogen, they cannot be accurately measured through the serum estradiol. Therefore, we do not recommend their usage because we don't know for sure if the extent of that estradiol level will affect our clients. The hormonal monitoring schedule should occur every 3 months in the first year and once or twice a year afterwards. The timing of the monitoring is also very important to note here. For oral, gel, and patches of estrogen, they can be monitored at any time. However, for injections or injected estrogen, you need to be able to monitor during the mid-cycle of the injections to make sure that the level that you provide to your clients is the accurate ones. There's also other kinds of screenings that needed to be conducted as well. More importantly, bone mineral density and prolactin level checkup. For BDMD screening, those who receive feminizing hormone therapy can follow the similar routine to the general population, so it's not the news, right? However, for osteoporosis screening, this should be considered at the baseline visit, and for those who at the low risk of osteoporosis, the screening can be conducted again at the age of 60 years old or more. However, for those who are at higher risk of osteoporosis, for example, trans women who undergone orchiectomy but did not receive or use estrogen, they are prone to osteoporosis, and that the bone mineral density checkup could occur or should be conducted earlier than the age of 60 years old. For prolactin level checkup, this screening should be considered at baseline and every 1 to 2 years after they are receiving the high dose of estrogen. And moving along to masculinizing hormone therapy. The masculinizing hormone therapy also possess the similar principles as the feminizing hormone therapy. The first thing is then we are trying to increase the masculine characteristic through the use of testosterone. The second objective is to reduce the feminine characteristics. However, luckily, testosterone can actually achieve both objectives without having to add anti-estrogen into the mix. Therefore, the primary agents for masculinizing hormone would be testosterone. These hormones also comes in many forms, right? We also have oral pills, we have injections, and we also have the patch and the gel. However, the most available form of testosterone in Thailand is actually injections. These hormones, the dosage for each form is written in the panel that write self guideline there. For testosterone enanthate and cypionate, the initiation dose would be 100 to 200 milligrams intramuscular every 2 weeks. 1 ampoule of testosterone enanthate actually contains 250 milligrams. So at the clinic, at Tangerine Clinic, we would usually start at 125 milligram every 2 weeks, and that is equal half an amp every 2 weeks. For testosterone undecanoate, the initial dose is 1,000 milligram intramuscular every 3 months. These also offer in higher volume, so a lot of our clients also complain about how it hurts more to take the testosterone undecanoate, but it's more convenient for them because it's only every 3 months, right? And for the gel, the initial dose would be 50 milligram per day. These slides also show a practical guideline of how you can titrate testosterone enanthate in Tangerine Clinic, which you can also apply in your settings. Usually, we will start slow at 125 milligram every 2 weeks, which is half an amp per 2 weeks, and then we titrate up until our client has achieved the targeted level of testosterone in their body. Testosterone can also offer several desired effects, including the oiliness of the skin, redistributions of body fat, cessation of menses, which is one of the most desirable effects from masculinizing hormones, along with the increase in muscle mass and the deepening of the voice. Some of these attributes are irreversible, and you need to convey that to your clients. Those irreversible effects includes clitoral enlargement and voice deepening. And just like feminizing hormone therapy, nothing is without cons. Testosterone also offers a lot of medical risks, which we have to monitor, not contradict our clients from receiving hormone therapy, of course. And this medical risk includes erythrocytosis, with the cutoff point at hematocrit more than 50%. This is one of the more common side effects from masculinizing hormones and can result in cerebrovascular events. Therefore, a regular, complete background testing is needed to ensure that we are minimizing this side effect. Moreover, testosterone can lead to hepatitis, hypertension, sleep apnea, and hypertriglyceridemia. The target hormone level for testosterone is actually 400 to 700 nanogram per deciliters. Please note the difference in the parameters here because a lot of healthcare personnel also confused about the parameters nanogram per deciliter or nanogram per milliliters. I am one of them, so please be aware of that. Now, for the timing of hormonal screening. This varies throughout each agent the client received. For testosterone enanthate, hormone level checkup should be conducted at half a time between the injections. However, for testosterone undecanoate, hormonal level checkup should be conducted right before the next injections. And for those who use testosterone gel, hormonal checkup should be conducted at least 2 hours after applying the product on the skin. Other screenings and interventions include also complete blood count, again, especially hematocrit level, fasting blood sugar, lipid profile, along with cancer screening. For hematocrit screening, this can be conducted along with hormone monitoring services. So every 3 months in the first year, and then once or twice every year afterwards. And for fasting blood sugar and lipid profile, these panels should be conducted at least annually to determine the effects of the metabolic conditions. For those who have not yet had their hysterectomy done, cervical pap smear should also be conducted following the similar recommendations for that on the females. And for those who had the mastectomy already, this is also very important because the screening on the leftover breast tissue around the nipple area is still needed to uncover whether that person have breast cancer or not. So do not sleep on cancer screening among gender diverse populations, okay? Now we are moving along to an equally exciting part of gender-affirming hormotherapy, which is its drug-drug interactions to ARV and PrEP. Regarding gender-affirming hormotherapy effects on ARV, 17-beta estradiol was found to mildly decrease the area under curve of tenofovir and emtricitabine level. However, this decrease was less than 30%. Therefore, dose adjustment is not necessary when combining estradiol with the TDF-based ARV. Now, if we take a look at the ARV's effect on gender-affirming hormone therapy, we can see that there is some drug-drug interaction presented there. For example, for the testosterone, right? There's an increase in testosterone when you are prescribing your clients with the boosted protease inhibitors. However, some regimens, including regimens that include efavirenz and nevirapine, they can actually decrease the concentrations of estradiol and testosterone. However, the management for this is quite easy, which is to increase the dosage of gender-affirming hormotherapy and provide regular testing to make sure that the hormonal level is in the desired level. Luckily, however, we are now approaching the integrase inhibitors era, which is dolutegravir and bictegravir era. If you can see on the down here, bictegravir, dolutegravir actually offer no potential interactions to gender-affirming hormone therapy, and that makes it so much easier to consult with your clients and much easier to navigate. However, when we talk about we will talk about gender-affirming hormone therapy and PrEP, things might get a bit more complicated. As we all know, transgender women who use gender-affirming hormone therapy are not allowed to use on-demand or event-driven PrEP due to their drug-drug interactions between estradiol and tenofovir. However, in the recent pharmacokinetic study, IFAC-3, conducted by IHRI, led by our beloved Dr. Akharin, who sits like here from Chulalongkorn University, they shows further insights into the drug-drug interactions between FTAF-based PrEP and estradiol therapy. In this PK study, we conducted a two-way analysis among 20 transgender women not living with HIV to uncover the effect of estradiol to the FTAF-based PrEP and vice versa. We analyzed the level of both estradiol and PrEP when the participants were exposed to both, and also the period where either estradiol or PrEP was introduced. The result shows that the intracellular tenofovir and emtricitabine level in peripheral blood mononuclear cells and in urine were comparable when FTAF-based PrEP was administered with or without feminizing hormone therapy. This suggests that there is no clinically significant drug-drug interactions between feminizing hormone therapy and FTAF-based PrEP. And this opens so many doors to the further research around PrEP and their drug-drug interactions. This information has been presented in APAC 2023, and further analysis would be presented again in this year's CROIS 2025. Similar methodology has been conducted in IMAT study, and now we uncover the effect of testosterone to FTDF-based PrEP and FTAF-based PrEP and vice versa. These results were derived from an oral presentations by Dr. Akren in APAC 2023 as well. The plasma total testosterone concentrations when co-administered with FTDF-based PrEP show no statistically significant changes, suggesting that there is no drug-drug interaction between masculinizing hormone therapy and FTDF-based PrEP. However, when we administered FTAF, there was a statistically significant increase in plasma total testosterone concentrations. And last year, the further analysis on peripheral blood mononuclear cells, rectal and cervical tissues from IMAX study was presented in CLOID 2024. Regarding the interactions between FTDF-based PrEP and masculinizing hormone therapy, the levels of tenofovir and emtricitabine concentrations from all specimens, including rectal and cervical tissues, were comparable when both of them are co-administered. This suggests that there is no clinically significant drug-drug interaction between the two. However, when we move along to TAF-based PrEP, PrEP concentrations were actually significantly lower in cervical tissue when administered with masculinizing hormone therapy. These preliminary findings actually help inform our clients about their initiation on PrEP and also ARV, whether they can also live with HIV and also fulfill their gender identities. And with that, I would like to leave the stage with a few take-home messages before I end these keynote sessions. First thing, please be reminded that gender-affirming care is urgent and is necessary. Implementing hormone transition under the informed consent model and allowing the trained general practitioner like myself to provide the care and to participate, this can actually significantly reduce the barriers to access and promote safe and effective gender transitions. Secondly, social transition is also as important as medical transition. Unfortunately, many gender diverse individuals, they are still facing stigmatizations both internally and externally, which hinder them from becoming themselves. As providers, we are more than responsible to help facilitate that gender transition, whether it is medical or social transition, and we need to equally prioritize medical and social care. And lastly, policy advocacy should always be accompanied by the provisions of the gender-affirming hormone therapy. Trans and gender diverse individuals, they are still continue to face disparities in employment, violence, human rights violations. Gender-affirming hormone therapy can actually be a great entry point for you to bring out those who are in the community facing this disparity and try to uncover the data that they are possessing. Make them mean something more, right? Be more than providers, be their allies, be their friends, and be ready to advocate for them. And with that, I would like to acknowledge our sponsor and our partner CBOs, and thank you so much for your attention.